Okay, good evening. My name is Olivia Lee. I'm a associate professor of ophthalmology at the University of California, Irvine. I'm a cornea and uveitis specialist. Thank you all for joining us tonight for our community lecture series. The topic for tonight's lectures is thyroid eye disease. So I'm going to start the series of 3 lectures that you're going to hear tonight by talking about an introduction to thyroid eye disease and how dry eye plays a role in thyroid eye disease. So our outline for today's lecture, or my lecture, is we're going to cover these 4 topics. First, what is thyroid eye disease? And then the connection between the thyroid and the eye. 3 is the features of thyroid eye disease. And finally, we'll wrap up with dry eye associated with thyroid eye disease. So first of all, what is thyroid eye disease? So this is an autoimmune condition that causes inflammation and damage to tissues around the eye. If you've not heard this word autoimmune before, what it means is that the immune system that we all have to protect ourselves from outside invaders like bacteria or viruses that might hurt us, when that immune system, instead of blocking an outside invader, turns around and hurts our own body's tissue, that's an autoimmune disease. Thyroid eye disease can also sometimes be called Graves' ophthalmopathy or thyroid orbitopathy. And so these are some of the classic findings with this bulging of the eyes as if they're bulging out of their eye sockets. The eyelids are retracted and you can get redness of the whites of the eyes. But what is the thyroid gland and why are we talking about the thyroid gland when this is a lecture about the eye? So in case you didn't know, the thyroid gland is located in your neck, and the function of the thyroid gland is that it produces hormones or thyroid hormones, and these hormones are secreted into your bloodstream and they control your metabolism. For example, regulating things like your breathing and heart rate and body weight and body temperature, amongst other things. So you may have heard of these terms, hypothyroidism and hyperthyroidism, and these are conditions which we could simplify by saying underactivity of the thyroid gland or an overactive thyroid gland. So typically, if you think of a hypothyroid person, they're very cold all the time and they've gained weight, whereas a hyperthyroid person may have a rapid heartbeat and very thin and heat intolerance. And this type of person might be associated with thyroid eye disease. But in a moment, I will tell you that this isn't always true. So what's the connection between these 2 organs, the eye and the thyroid? Well, remember I told you that this disease is an autoimmune disease. And this kind of autoimmune inflammation or inflammation against your own self's tissues can target both the eye and the thyroid because there's a receptor that's found on both the thyroid and orbital tissues. And so the immune system, when it attacks, it's like making a mistake. It thinks that this tissue is an outside invader and it's trying to attack it, thinking it's protecting itself from infection, when in fact, this is part of your own body's normal thyroid tissue or normal eye tissue, and then it goes and attacks those tissues. But why these 2 tissues specifically? Well, the common element here is the thyroid stimulating hormone receptor that's pictured here in green. So on your thyroid, you have these, the thyroid stimulating hormone in red will attach to the receptor, and this is its normal function. And when this happens, then the thyroid gland makes thyroid hormone like it normally should. But where we can go wrong is if we have this thyroid stimulating immunoglobulin, which is an abnormal molecule that looks very similar to the attachment point on the receptor. And so it's like you have your car key that you stick in your car and you turn on the ignition, but for some reason your neighbor's house key can turn on the ignition as well. And so then you turn on all these cars that didn't mean that you didn't want their engines to start. And so this ends up activating things that you weren't supposed to. So you may have heard of this term Graves' disease. Similar to what I just spoke about, these molecules attach to the cells on the thyroid and activate the hormone and produce much more hormone than your body naturally wants. And this produces some of these symptoms that we were talking about, like fatigue, anxiety, irregular or rapid heartbeat, also enlarges the thyroid and can produce these signs we're talking about on the eye. So the incidence of thyroid eye disease, it's pretty rare disease, slightly more predominant in women than in men. And one misconception is that we think of thyroid eye disease as only happening in people who have Graves' disease, only happening in people who have hyperactive thyroid. But that's not always necessarily true, although you see in this pie chart that the majority of patients with this condition do have Graves' disease, but not all of them. And the eye findings may or may not mirror the systemic condition. So some people with the thyroid disease, it does correlate, how much thyroid problem they have can correlate with how much eye problem they have, but it doesn't always have to be that way. About 40% of Graves' patients develop eye disease, but some develop the eye disease first, some develop the hyperthyroidism first, and some of them together. It's not always symmetric. There's also a category of patients that you'll see here in red called euthyroid, who actually have normal thyroid function. So in other words, it's not a prerequisite to have abnormal thyroid function. You could have totally normal thyroid function and still have thyroid eye disease. What are the symptoms of thyroid eye disease? Well, that bulging appearance of the eye where the eyeball is sticking out of the eye socket, that's pretty typical. You can also have inflammation of the eyelids, and we'll talk much more in my lecture today about dry eye that's caused by thyroid eye disease. You can have red or bloodshot eyes. The eyes can be painful, and in severe cases, we do get impaired vision from multiple causes. So what happens to those eye tissues when they are affected by the autoimmune inflammation that's associated with thyroid eye disease? Well, let me first show you a picture of what the normal anatomy of the eye tissues are. So here we have the eyeball. It's located inside the eye socket. The walls of the eye socket are made out of bone, and inside the eye socket, we have other tissues as well. We have eye muscles. These eye muscles control if you're looking up, down, left, or right. And then you also have some fat inside the eye socket to protect these structures. And you can see the position of the eyelids on the outside here. But very importantly, on the inside of the eye socket, you have the optic nerve that connects the eyeball to the brain. So that optic nerve carries the signal of vision from the eye to the brain, so the brain knows what the eye is seeing. And it's a very, very important nerve. So this is a normal eye, and this is an abnormal eye affected by thyroid eye disease. So you can get the fatty tissue expands, the muscles that help you look up, down, right, and left also become very thickened and swollen. And because the eye socket has walls made of bone that will not change, it can't get bigger. It's like you have too much furniture in your house, and now the furniture is coming out the front door. That's why the eyeball starts to bulge forward, because there's no bone in the front. And the eyelids are the door, and they can't close all the way, so the eyeball is sticking out past the eyelids. This causes a lot of different problems that you'll hear about today. So how is the diagnosis of thyroid eye disease made? Well, there's a lot of different testing that we can do. And when you come to our office, you sit in this chair, and we have all these devices in our office to take a look at your eye. We measure your we can measure different things like your vision and the peripheral vision test or the visual field test. We can check your color vision. We often check your eye pressure. Typically that's for glaucoma, but it's also very useful in this situation. And we can do some scans or imaging of the eye and the optic nerve and other structures. We might also send you for some blood tests because we talked about earlier that the thyroid hormones and those thyroid antibodies are associated with this disease. We can check those in the blood. We might also order imaging of the eye sockets and the eye structures with either a CAT scan or MRI. And so here you can see this is what a normal scan of the eye and the orbit look like. So here's your eyeball. Here's the bone surrounding the eye socket. Here's that optic nerve we were talking about. And these are the eye muscles that help you look right and left. And in the thyroid eye disease patient, you can see that that muscle right there became this huge muscle over here. This muscle on the right became this big fat muscle over here. And so you can see that those two muscles are putting a lot of pressure on that really important optic nerve that carries the signal of vision from the eye way back to the brain. So here are some of the features of the thyroid eye disease, and I'll just go over them quickly. We're probably going to go into much more detail in our subsequent lectures. So eyelid and periorbital signs are very common. So here you see a picture of eyelid retraction. You see that that upper eyelid, typically, it does cover the top of the cornea, or the colored part of the eye gets partially covered with the eyelid, but you can see that in this case, the upper eyelid is really retracted far back and gives you that look of like the patient is really staring at you because you see so much of the white sclera showing above and below the colored part of the eye. Exophthalmos is a fancy word. Also, proptosis is a fancy word, and what it means is bulging of the eyeball. So imagine that back here in your eye socket, you have all these structures that usually take up a certain amount of space, but now they've gotten a lot bigger. So the eyeball is nowhere to go but out forward. And this is that bulging look of the eyeball. And after that, the eye muscle involvement. Remember, we talked about there are eye muscles inside the eye socket that help us look up, down, left, and right. And when those are involved in the disease, especially the severe forms, you can see that this eye is looking straight ahead, but this eye is looking off to the side. So the two eyes have difficulty looking at the same place at the same time. This will certainly give you double vision. And then the optic nerve that we talked about that carries the signal of vision from the eye to the brain, if that is damaged by the disease because the eye muscles are so large and there's just so little space, it squishes on the eye, the optic nerve, it can really hurt the optic nerve. And you'll hear a lot more about that with Dr. Patel's talk. But only 5% of patients have all of these findings at once. And now let's talk about why thyroid eye disease causes dry eye in particular. So the bulging of the eye, or the eyeball coming out of the eye socket, means that more of the surface area of the eyeball is exposed to the outside elements in the air than normal. So in a normal eye, you'd have the upper eyelid here, the lower eyelid here, but in this case, you have a lot more surface area of the eye that gets exposed to air. And those eyelids do serve to protect our eye from too much exposure to the dry air in the atmosphere. So we get the moisture evaporating off the surface of the eye, and that's why we get dry eye symptoms. In really severe forms of the disease, the eye bulges forward so much and the eyelids retract far back so much that the eyelids cannot even close all the way. And then there's an area on the eye that is always exposed to air. And it never gets wet when the eyelids try to close, because the eyelids will close like this and they never touch. So the eyelids, although They protect the eye from getting too dry. They also serve another very, very important function, which is every time you blink, you're spreading a fresh layer of tears over the eyeball. So you think of the eyelids as a paintbrush that paints a fresh coat of tears over the surface of the eyeball. So if those paintbrushes are missing this area, then that one area is constantly being exposed to air. Once the tears evaporate, you don't get more tears because the paintbrush is missing that area. In really severe cases, the eyes bulge out so far that the eyelids can't close at all, and the exposed area gets so dry, so irritated that the healthy cells slough off and that area can get really infected. So this is really, of course, a severe complication of the disease that we would never want to happen to anyone. So we want to definitely catch the disease before it gets this far. So what are the treatments specifically for the dry eye that's caused by thyroid eye disease? You'll hear about other treatments for thyroid eye disease later, but specifically I wanted to speak to the dry eye portion. So in mild cases, we simply add more moisture from the outside with artificial tears. These are things you can buy over the counter in any drugstore or pharmacy. You don't need a doctor's prescription, and they come, generally speaking, in 2 flavors. So anything that comes in a bottle with a screw-on, screw-off top will have some preservatives in it. So if you're using it 1-2 times a day or once in a blue moon, it's okay to get the ones in the bottle. But if you're going to use the artificial tears 4 times a day or more every single day, we suggest going for the preservative-free artificial tears that come in these snap-off vials. So these have a little top that you snap off and then a small reservoir of a couple of drops. And 1 drop at a time is enough. So frequency is more important than volume. You want to put these several times a day if you have a very dry eye. And then every night before going to sleep, we suggest a moisturizing gel or ointment. And there are some that are thicker than others, but generally these are for nighttime use because they are so thick that it really blurs the vision. So you don't want to put the ointment in the eye during the daytime hours. If you're going to drive or read or use the computer, it will blur the vision. But if you're doing it at night when your eyes are closed and you're sleeping anyway, then it's okay. And it will last for a very long time because the ointment is much more viscous. But in more moderate cases, especially where there's a lot of surface area of that eyeball that is exposed and you're losing a lot of your natural tears to evaporation, you're also going to lose a lot of the artificial moisture that you're putting with those over-the-counter drops. You're going to lose that moisture to evaporation as well. So in addition to the things I just said, you might want to invest in a room humidifier. Doesn't matter which brand, but this is of limited usefulness, especially if you're in a really large room or if you're moving around all the time. But if you are someone who loves to read, or you have a Kindle that you look at all the time, or you watch a lot of television and you're always sitting in the same spot, put a humidifier there to increase the moisture of the air that's going by the eye. And then we can also talk about moisture chamber, which means that we create a chamber where all the moisture is trapped here, and the outside air, whether it is dry, whether it's humid, doesn't matter, because you trap the moisture inside. So you put your artificial tears, and then you put this is a sticker that is like an eye patch, and it's got a plastic bubble in the front. So once you apply this patch to the eye, that sticker seals off any outside air from getting into the eye. Or you could buy these moisture chamber glasses, and so they look from the front like normal glasses, and from the side they have the silicone padding so that it touches your skin. So that what's different between these glasses and normal glasses is that the air cannot pass in from any direction. And a lot of patients who can't close the eye all the way have severe drying when they're sleeping at night. Imagine that you go so many hours during the night where there's an area of your eye that is not closed. So we recommend those patients put on these sleeping goggles. It also prevents the light from entering the open eye in case you need that for better sleep. And in really severe cases, then we talk about doing surgery to help the eyelids close and to help that the eyes don't bulge forward so far. And we'll be talking more about those surgeries from our next two speakers. So that's the conclusion of my portion of the talk. And if you want to be evaluated for dry eye or thyroid eye disease or any other eye conditions, we'd be happy to help you. We have two locations, one in Orange, one in Irvine. The phone number is the same, or you can visit our website. And I thank you very much, and I'm happy to take any questions. Please either put them in the chat or speak up, and I'm happy to take any questions now. Or if you have questions for our other two speakers, we can also wait for their talks as well.
Okay, well then with that, we'll just cut right over to Dr. Patel.
Yeah, there it is. Thank you, Olivia. That was a really good introduction that kind of set the stage for thyroid eye disease and a really common complaint, which of course is dry eye. And as Dr. Lee mentioned, I'll just talk about a few more aspects of it as we keep going. It's a pretty complex disease that takes a number of different specialists, not only within ophthalmology, but endocrinologists and surgeons and so forth, managing the thyroid condition itself, as well as the eye disease. It's very multidisciplinary, and there's a ton of new advances within it as well. So what we're going to do is just going to go through a few things. And this is historically kind of how we've managed thyroid eye disease, okay? Like all stages, we'll talk about it being kind of mild, moderate, severe, and we can go through it that. At all stages, it's recommended to stop smoking because there's a very strong connection between thyroid eye disease and active smoking. And there's some complex biochemistry behind that, but it's a veritable fact that smokers tend to have more severe thyroid eye disease, so it's the very first thing that should be done. Maintaining euthyroidism, which means that getting out of the hypo or more commonly hyperthyroid stage is very important. So that's where working with the endocrinologist is super important. We will commonly say that the thyroid eye disease can kind of beat to its own drum, meaning it doesn't have to be the same as the thyroid condition. So somebody could have a very well managed thyroid condition in that their hyperthyroidism is in good control, but their eye disease continues to progress. Others have very bad control of their hyperthyroidism, but there is no eye disease. But there is certainly an overlap, but we can't assume that there is going to be this 100% reciprocity. That being said, you want to control the thyroid as well as you can and cut out whatever connection there might be. When it's mild, we've been generally saying wait and see, which means I'll show you a couple of photos, meaning that a little bit of lid retraction, a little bit of congestion, not much in the way of strabismus, which is double vision, no real proptosis or exophthalmos, as Dr. Lee mentioned. Sort of wait and see, kind of just see how they do. Moderately severe, usually immunosuppression. What does that mean? Usually steroids or other medications, and we'll talk about that. Even radiation to the orbits can be helpful, and it has been historically helpful for people with active thyroid eye disease, which means people with lots of congestion, redness, inflammation. And then we see moderately severe kind of rehabilitation surgery when it becomes inactive. Inactive means you can have really bad proptosis, you can have really bad strabismus, you can have bad dry eye and all of these things, but the eyes aren't super red, they're not super congested or angry looking, there's not a lot of swelling, but it's just kind of an advanced stage of strabismus or proptosis. And that's optimally this stage at which we tend to address surgical maneuvers and so forth, because you don't want to go into a hot fire, like a mess, in a sense. If everything's swollen and inflamed, you want to calm that down before we go forward and offer anything more invasive in terms of surgery and so forth. Now, as Dr. Lee mentioned, there are sight-threatening situations, not only double vision and so forth, but when those extraocular muscles become so large, the optic nerve can get compressed. And there we will give high-dose methylprednisolone, which is steroid, or we'll do a decompression or newer agents like we'll talk about in a minute, known as Tepezza. Now, important to mention this, as I mentioned, that smoking and risk of TED, the odds ratio, meaning the relative risk of developing thyroid-associated ophthalmopathy, is much higher than the average Graves patient if one is actively smoking. So as I mentioned, there's good evidence behind that. And also, radioactive iodine, this, for those of you that may be familiar with treatment for hyperthyroidism, one of them is just take out the thyroid gland, which is called a thyroidectomy. Another one is using medications like methimazole or propylthiouracil. These are just oral agents that help control the thyroid. And then there's others that get radiation. Basically, they swallow a radioactive pill, and then that helps digest or damage the thyroid gland. We find that in patients who are smokers and they have radioactive iodine treatment, their risk of progression of the thyroid eye disease is higher. So we take all of these things into consideration when looking at how to bring somebody under good control for their thyroid, and taking into account their history of smoking, taking into account their presence or absence of thyroid eye disease. So people who have thyroid eye disease shouldn't be smoking, and they probably shouldn't be having radioactive iodine, even if, in particular, if they're smokers. So those are some things to keep in mind. So as we mentioned here, this is kind of like somebody with eyelid retraction. Okay, a little bit, you can see Dr. Lee was pointing out, this is the normal side, the left side. The upper eyelid just covers the top of the colored part. We call that the limbus. The limbus is the meeting point between the iris and the cornea, as well as the sclera, which is the white part. And that's normal configuration. Whereas here, she doesn't, look to have a very abnormal state, but this is mild thyroid eye disease where this upper lid is retracted. Here, it's just sort of conservative measures, okay? Now, when we have retraction and a bit of swelling, you can see that there's some retraction, something known as lateral flare, meaning the outer portions of the eyelid become more flared out. And that's a very common look in thyroid eye disease, and some periorbital edema, some swelling of the tissues surrounding the eye. That could be in the lower eyelids or the upper eyelids. And they're, again, conservative measures. What might your doctor recommend in addition to the dry eye management and so forth, which is invariably a part of this phase? Selenium. Selenium is a naturally occurring element that we find it's found in the soil. And it's found, we're in a fairly selenium-rich area. So it's uncertain whether selenium supplementation will work, but there have been a couple of studies, larger studies out of Europe, that showed that selenium supplementation can actually help with some of this stage, some of this periorbital edema, some of this kind of mild congestive features. And I have many patients who are trying it because there's very little to lose on that. And some feel that it really helps. So I suggest it for everybody, but it may not be something that is the treatment that you're looking for, but something at least that can help you. A low salt diet, because sometimes we notice that if you're having lots of salt, you trap swelling, and that causes more water retention, and that can also affect these tissues, which are becoming boggy and swollen. So a low salt diet, as we mentioned before, good thyroid status control is always key in a more global sense for these patients. Now it starts to get more obvious. When you get eyelid congestion, you can see this upper eyelid is swollen and thickened, as well as the lower eyelid. It extends around what we call periorbital tissues. The eyelid retraction is worse. You can now start to see part of the sclera above the limbus and below it. That's called inferior scleral show and superior scleral show. The sclera is the white. So if you're showing sclera, it's called scleral show. And that's what's happening. And more proptosis. Of course, if your eye comes forward, then more of the sclera is going to show, because as Dr. Lee showed, the swelling behind the eye, the orbital fat, the orbital muscles are becoming swollen. So the eye has nowhere to go but forward, and therefore you get that congestion. Okay. And the so-called proptosis. Now, usually that's, of course, conservative measures. These are additive measures. So it's not like the conservative measures don't apply, but they may not be enough. And I want to introduce this concept or this new medication called Tepezza. Many of you may have heard of it. It is an immunological therapy in the sense that it's given intravenously, and the initial phase of it is given every 3 weeks for eight separate treatments, so a total of 24 weeks. And it came on the market, FDA approved in January of 2020 for specifically thyroid eye disease. And it was initially studied for patients with active disease like this patient here. And now it's being sort of extended to all thyroid eye disease patients. But your doctor, of course, will work closely with you to determine if you're a good candidate or not. but it really is the only FDA approved medical treatment for thyroid eye disease. It's not going to be for everybody. And like every agent, one has to figure out where it fits in the treatment sort of protocol for a given person. But it has a significant promise, and I have many patients on it for the right situations. But someone like this that comes in with that level of congestion, retraction, proptosis would be a good candidate in as long as there's certain things that are satisfied. And we can talk more about that if you're interested. But that is a bit of a game changer, something medically that allows us to truly affect the pathogenesis of this disease, which we haven't had before. Now, you can have severe retraction and surface exposure, as Dr. Lee showed. When your eyelids are so retracted, this middle portion, what we call the interpalpebral zone, the zone in between the lids, is not covered, and that stays chronically exposed, and you can get this severe redness and scarring in that area. So, of course, this often you have to improve the proptosis, but also do eyelid surgery that Dr. E may talk about in a little bit, where you try to just improve that amount of surface exposure and reduce how open those eyes are. Okay, and that's part of it as well. Now, Tepezza can work, steroids if it's active and inflamed, orbital decompression, which Dr. E will talk about, where you actually take away some of the fat and the bones that surround the orbit to literally make room for the eye and all this extra tissue to push everything back. So you're actually taking away bone, breaking the bones on the lower half and the medial part, and sometimes laterally as well, to make room for the eye to settle back in its normal position. And we talked about the eyelid surgery as well. Now look at this. These are all real patients with thyroid eye disease, and you can see how wide of a spectrum of disease we can have. And these patients have, severe swelling, congestion, and mild proptosis. Here, the eyes are not coming forward as much as that last patient, but look at how much more swelling there is. There's so much active congestion here. But this is the patient that needs to put the fire out. This is so swollen that we have to reduce that amount of congestion in this situation. This is where steroids and Tepezza and so forth can be really helpful. Okay. And even orbital radiation. Now that's sort of fallen out of favor to some degree because of Tepezza and because we have other medications now. And it was never globally kind of adopted. But it is something that can work in super active cases, but it's nice to have options. It's nice to have things that we can do, because not everyone is going to be appropriately managed with one treatment or one type of treatment. And I write here, watch the optic nerves closely, because again, as Dr. Lee mentioned, those optic nerves can get pretty squishy back there. So when we're looking at the back of the orbit here, these are the eye muscles. This is the upper muscle, the medial muscle, the lower one, and the lateral one. And you can barely make out the optic nerve. It's getting too close for comfort in between these puffed up muscles. And if you compress that optic nerve, then you're not able to get that information from the eye into the brain. It's kind of like squeezing a cord. And if that cord cannot conduct whatever it's try to conduct, you're going to be out of luck. And you can see here on the other side, there's even more congestion. You cannot make out the optic nerve around the extraocular muscles. And these patients can present with pretty severe vision loss. And here we have kind of days to weeks to act. When somebody has this level of compression and they have compressive optic nerve changes or compressive optic neuropathy, we need to do something, whether that's Tepezza, steroids, orbital decompression, usually within days to weeks, because we're trying to prevent permanent vision loss in situations like that. The good news, though, is that when you do act in that timely manner and you make that diagnosis, patients do extremely well. Okay. And now, again, showing you various examples because it comes in so many flavors, and there's never one way to look at for thyroid eye disease. And you can see the same. You can see the significant proptosis, but minimal congestion, not a ton of congestion in this situation. Again, similar kinds of stuff, not super active. We can push the eyes back either with decompression or with Tepezza. And then you do eyelid retraction surgery, what Dr. E or her colleagues can bring down the eyelids so that they're more in position, or bring up this eyelid where it's in better position as well. And that's usually done last. Okay. And this is a post-decompression picture, literally removing the bone. You can see that this bone, this orbital bone, has been removed down below and medially, and even on this side, medial and down below, just to make room for those huge muscles. Those muscles are 4 times the size of what they should be, or at least 3 times the size of what they should be. And therefore, there's only so much room to go around. And if you got that much compression, you've got to make room. And the way to do it most directly is by creating room on the orbit itself. So that's what that picture is. So essentially, the part that I'll end up with, which is the area that I specialize in, is the strabismus part. Now, many patients don't need surgery, and they can be managed with prisms, which could be a stick-on prism or prisms that get ground in the glasses. And if they have double vision, this can be a really, really helpful thing for patients. Now, sometimes the misalignment is so great, meaning their eyes are quite far out of alignment, that prisms are not really practical, at least as a primary solution. They may be after a surgery, but primarily, if the eye alignment is too great or misalignment is too great, we need to do something to realign them. And that means strabismus surgery, okay? Now, we've got many techniques, and you just have to do a lot of it to know. Here is the prism I was mentioning. This is what's called a Fresnel prism, Fresnel, Fresnel. And these are literally just stick-on prisms, okay? And they can blur the vision a little bit, but they can be really helpful, especially when, you don't want to necessarily pay for glasses that get ground in prism, because prisms can be expensive, or you're not due yet for changing your prescription and so forth. These practical concerns can be obviated somewhat by a Fresnel prism, because that can be stuck on directly, and we can do that right in the clinic. It's also good for patients that have a variable strabismus, meaning that we're not sure whether their strabismus or their misalignment is going to change over the next several weeks or months. And instead of buying several pairs of glasses per month, or not per month, but per year, that are expensive, sometimes we can just change that Fresnel prism several times, and that can just give somebody relief and have that variability and that adjustability as needed, okay? And this is what we use. We use these prisms to measure what your deviation is. It can be a vertical deviation, it can be horizontal, and we measure it out. It's often both in thyroid eye disease, so it can be relatively complicated. But now when we get back to surgery, and I had this scenario just today, these extraocular muscles are very congested, they're tight, they're restricted. So what they do is they pull the eye down, or they pull the eye into the nose. And what we need to do is make room. We need to release those muscles and realign the eyes by making those muscles less tight. And the way you make them less tight is by sliding them back on the eye. You recess them, you push them back so they can't pull as hard, like a belt. If you've eaten too much for dinner, you loosen your belt and you put it two holes down so that you're not as tight. Same kind of thing, okay? So a recession is a weakening of the muscles by just sliding it back, okay? And we have all kinds of techniques. I don't want to get too much into the weeds here, but we have all kinds of techniques to do that. And this is what we call an adjustable suture technique, where we can put you under for the surgery, tie the knot in a way that it's adjustable when you wake up. So a few hours after surgery, sometimes the next day, depending on when the surgery is done, we tie the knots in a way that we can slide this knot up and down to give us some adjustability. And that's not for everyone, and it's not for every case, but it's something that we can do to help improve our success. So take an example here for a pre-op, and I drew a line across the eye so you can see that significant amount of vertical misalignment. And here you can see that this is a difficult way to have visual function, because you're seeing, two images very far apart from each other. And this is same day post-op, meaning an adjustable case, where we're actually able to adjust the alignment, because each case is different. All 30 of us on this call, if we have the same amount of thyroid eye disease, there's going to be several different parameters that we have to take into account. And there will not be a single formula for all of us. Okay, so that's important to keep in mind. Another case here, somebody's having a hard time looking up. This left eye is tight, not looking up, looking down. It's overzealously looking down, looking to the left. You can see this eye is pointed down, and that one is pointed up. All kinds of madness, for this person is not able to maintain their single vision. So same situation in thyroid eye disease. And what we can do is weaken the muscle down below on that left eye and weaken the upper one up top to bring them together. So there's various strategies that can be done. Okay. And that's the strabismus part. And I'm going to turn it over to Dr. E, because she's going to talk about the eyelids and decompression and anything else she wants to talk about. But I wanted to just sort of put it out there, and maybe we can do the questions afterwards again, just to stay consistent. Thank you.
Thank you, Dr. Patel. There is Dr. Ediwrickrema. Thank you very much. Over to you.
Okay, great. Hi, everyone. Thank you, Dr. Patel. It was always a great presentation. So let me can everyone see my slides?
Not yet, Lilangi. Oh, there we go.
Okay, perfect. There'll probably be a little bit of overlap, but I'll try to focus on the kind of the orbital management or, surgical intervention options. I will also highlight upon Tepezza as well, because I find that most of my patients have questions about that. So no disclosures. So as has been mentioned, I think it does help to have some repetition because it is kind of useful to solidify something in your mind. It is the most common source of most common etiology of bulging in the eye, whether it's on one side or both, is disproportionately more commonly found in women and those who smoke, as Dr. Patel mentioned. There's a host of ways that patients can present with thyroid eye disease, and there's been several demonstrative pictures that Dr. Lee and Dr. Patel have shown, leading to swelling, redness, and discomfort in and around the eyes, manifesting in double vision and even vision loss if very severe. So when thinking about patients with thyroid eye disease, most are hyperthyroid, but some can be euthyroid, and even a select, less than 5% will be hypothyroid. Of those who are hyperthyroid, about a third or less than a third will develop thyroid eye disease. And then just for those who kind of are curious, autoimmune disorders tend to happen together. So if you develop one autoimmune disorder, you're more likely to have another one than someone who doesn't have one. There are systemic findings with patients with thyroid eye disease. It's important to be mindful of extremity dermopathy and acropathy. This is one of our patients who, it's a multidisciplinary approach to the management of several of these patients. So teamwork approach, the cornea services, which Dr. Lee represents, the neuroservices service that Dr. Patel represents, and also neuro and plastics, in addition to endocrine and, your primary care doctor. In terms of thyroid eye disease, you can either be a kind of a lump or a splitter, and it's kind of an overall overgeneralization, but one tends to think of it being sort of a type 1 versus type 2 disease, where younger patients get sort of this fatty enlargement behind the eye, and older patients get this enlargement of the extraocular muscles, and they're more likely to present or develop double vision. So in terms of treatment paradigm, it's been described for those that have mild ocular surface irritation and dry eye. You can start with lubricating eye drops and the goggles and everything, as Dr. Lee mentioned. Moving on to whether you do Botox, steroids, radiation, and biologics. And then surgically, we have, as Dr. Patel mentioned, the traditional approach is to really start with orbital surgery if necessary, then muscle surgery, followed by eyelid surgery. And in terms of the biologics that have come out, there's been a few that have been studied, but the one that's really been validated and now FDA approved as of January 2020 is teprotumumab or Tepezza. This is one of my patients that had orbital decompression. I'll kind of focus on that first, and we'll talk a little bit about Tepezza. As you can see from a worm's eye from above, this patient actually had corneal scarring. And so after a unilateral balanced decompression, where I sort of shaved off the bone laterally immediately, which means on either side of the eye, you can see that it's kind of come in, and you don't see that it's extruding outward. So the patient can now close the eyelids over. It's really important when I look at these patients to really evaluate their scans before surgery, make sure nothing else is going on. There's no sinus disease. The bone is still intact where we're going. You really want to look at the skull base. There's certain things that, we look at. But the main thing I just wanted to show you guys is that, we're targeting really important areas of bone that's dense to really create space for the muscles to sit and move. There's been a lot of studies that have looked at how the type of surgery you do and how you open things up really affects alignment, improves or exacerbates double vision. And some people believe you can go ahead and treat the eyelids like the retraction at the same time as decompression. So it's kind of a moving or evolving target, especially now with the use of biologics in this space. So in terms of the bony anatomy, or sort of how I tend to approach this, typically you can approach the orbit or the space around the eye. So your eye sits in kind of like a house, and the house has walls, and the walls are essentially the bones. You know, if you actually look back in the literature, the first bones that were removed to make space was actually the roof, which is, if you guys can imagine, that the other side is the brain. So this was done by neurosurgeons, and they don't do that anymore. We don't do that anymore. But in terms of approaching and creating space, you can use this lid crease as seen here in the green line to get to the outer side, the lateral wall. You can use the yellow incision here to kind of get to your inner part near your nose, and then this magenta to your lower lid. So using kind of the color matching, I like to start, unless there are other certain situations, but traditionally you get the most bang for your buck for a lateral wall decompression. And this has been shown by multiple people. And in terms of targeting where you remove the bone, as well as you can extend outer and even get the rim if you want it at the time. Then typically one usually does a balanced decompression going in to the kind of near where the space between your nose and your eye. And this, especially if you maintain your kind of this something called a periosteum, you can really, there are theories and there's been data showing that you can minimize shifts in the muscles and really try to prevent at least worsening. You don't want patients who don't have double vision to develop double vision, for example, if you can avoid it. It's not always possible. And then the floor is a great option, especially if you need space very quickly. It's very easily accessible. And you have to be careful where you remove the bone. If you go behind a certain place or take out too much, your eye will sink into your cheek. Back in the day, people would go through the roof of your mouth to approach this, which is really rarely done these days. So it's been shown by multiple, by a key study, but then several others as well, that if you kind of approach it sort of in a systematic way, you can have a predictable reduction in proptosis, which is this bulging effect that occurs in and around your eye based on which walls you take. And one thing I didn't even include here is there's tons of fat, and I'll kind of show in a subsequent slide why that's important. In removing the fat, especially the deep orbital fat, you can get quite a bit of reduction as well. I did want to go over teprotumumab actually in a bit of detail, mostly because so many patients have questions about it when they come to me. And so this was approved in 2020. It was approved for active thyroid disease, but they're currently enrolling. I'm not sure if they're still enrolling, but looking at other applications for things like inactive and other indications for patients to receive this medication. So it targets the insulin-like growth factor 1 receptor antibody or receptor protein. And the reason that it works is because, and this is sort of a busy slide, is that it's really a pro-inflammatory landscape that exists. So you have, what that means is there's a bunch of cells that create an environment of inflammation. And then that inflammation then essentially activates other cells to lay down more something called glycosaminoglycans, but that leads to making your fat compartments get really big and your muscles to get really big. And as Dr. Patel showed in some of his great imaging slides, that creates, you run out of space. The orbit is a tight space. So once you start pushing on adjacent things, you start, pushing the eye out, you start getting double vision, or you start kind of compressing the optic nerve and you can get the vision loss. So as mentioned, it's 8 infusions over 24 weeks. The things they looked at was the improvement of the bulginess, and also something that's really important, something we've monitored, which is called a clinical activity score. So, which is how is the patient presenting? Do they have pain at rest with eye movement? Is there swelling, redness? all of that goes into play. And then they looked at quality of life improvement and improvement in double vision. And so the important thing to take away from this slide is that those enrolled were between 18 and 80, so no one less than 18. They looked at the improvement in a host of things, so double vision, proptosis, and they excluded a few other, if patients have had prior treatment with other agents. So this is like the money picture. This is the one that is circulated everywhere. So the top row is essentially a patient who didn't receive the treatment and they look possibly even worse afterwards, or stable, versus this patient who is demonstrating a very significant improvement in their bulginess, their redness, the retraction, which is, again, you typically don't see the whites above and below the eyes. And so in this publication, the seminal publication did show improvement in the caliber of the extraocular muscles, creating more space after treatment as well. And Dr. Patel has done studies with this, and so this has been really validated to be effective. So the cool thing is it does work. It works with improving proptosis or the bulginess. It improves patients' quality of life and improves double vision. And I definitely see that in a lot of my patients. I will take this moment to say that the patients that I find, I don't think it definitely takes away surgery. I think it usually takes away how many walls that I mentioned earlier. There's 3 walls that we usually use, and then you can add the rim and fat. But instead of needing 3 or 4, you may just need 1. And we're also finding with recent analyses looking at pre and post patients and looking at some I guess prognostic indicators that type 1, those patients with the fat predominant, the younger patients, are actually less likely to improve from or are more likely to improve with surgery than teprotumumab. And so that's something to consider when you're counseling and choosing your patients. So adverse effects. So this is another thing my patients will ask me. And I think one thing that people are always concerned about, if they've heard about it already, is that sometimes there's hearing loss. And Dr. Patel and Dr. Lee can chime in. But from what my understanding is, most of the patients that did develop this, if not all, actually had resolution of that hearing loss once the transfusions were stopped. There were no deaths. And then there were typical side effects as one might expect from medications. The main thing is teratogenic. So women who are considering pregnancy or are pregnant cannot have this medication. And then after it went into the market, there's been effects on menses as well that's been reported. And the last thing I'll just say, and we don't have to kind of belabor this, but there's a new trial that looked at, hey, if you didn't respond with the first 8 infusions, with more infusions help, and it does seem like some do improve with more infusions. And this last slide is just really showing that there seems to be good applicability even in those patients that are having that really urgent indication for surgery, which I think I tend to be in the camp of steroid surgery. But if you are able to act really quickly, get the patient to teprotumumab, and especially in the patients who are poor surgical candidates, they do also seem to respond really nicely to teprotumumab. It's evolving with access and everything, but I'm happy to take any questions now.
Thank you, Dr. Ediwrickrema and Dr. Patel and Dr. Lee. Does anybody have any questions? I don't see anything in the chat just yet. Feel free to raise your hand if you'd like. If you have a question, and you can unmute yourself to ask.
Go ahead, Lily.
What caused the buildup of the fat behind the eyes?
Did you say what causes the edema in the fat?
Yeah, buildup behind the eye.
So that's the slide I was showing. Let me pop it back up. But essentially is this expansion of glycosaminoglycans and laying down of, it's just a pro-inflammatory landscape. And then there's osmotic shifts. What that means is there's fluid that gets kind of sent in. I'm trying to share this one slide. Can you guys see this? So
Yes.
essentially you have these antibodies that bind to certain types of cells, and then they differentiate, they lay down these things called hyaluron and glycosaminoglycans, and then that's what causes the orbital fat expansion.
And what kind of lifestyle change, even after you have TEPEZZA and surgery, how can we maintain it? Because I feel sometimes if I do certain things, my eyes are worsened. So for long-term purpose, how can we maintain the progress that we made?
So, I mean, there's a lot of things to consider, and Dr. Patel mentioned some. First of all, just general, starting at, the basics. How are you being managed with your endocrinologist? It's not directly correlated, but your blood levels and your medications, if you're active in terms of your disease, your disease that affects your body, that is something that can, reactivate or change your thyroid eye disease course. If you're a smoker, that is probably the worst thing to do. You can take selenium, but as Dr. Patel mentioned, maybe not as effective as in those in Europe. And then you have to really think about where are you in this disease. It's a long-term thing. When I meet a patient with thyroid eye disease, I tell them this is like high blood pressure. We're going to be managing this for the rest of your life in some way, most likely. And so really you have to think about your exposure. You have to think about your muscles. You have to think about your orbit and then how things are changing. Dr. Patel, I'm sure, has some ideas as well.
All of that, I think it's important. And there, as you said, the thyroid control is one. There's lots of interest in diets that may be a little bit less inflammatory, or, so-called autoimmune diets. And I think that's probably something we don't emphasize enough and don't know enough about, in terms of this. But there are lots of folks who have autoimmune diseases who find they're more comfortable and better controlled when they modify their diet. So I actually suggest to some folks who have questions like you to work with a nutritionist to try to think about foods that may be, high in inflammatory indices and trying to reduce that a little bit, lower salt intake. All those, I think, can make a difference, in addition to directly, targeting the thyroid chemistry itself. But this is at the end of the day an autoimmune condition. So if we can control those underlying factors, diet may be part of it that one can explore, I think, in addition to just the maintenance of things. Now, we're learning about this TEPEZZA as well, and I kind of analogize it to this as if you had rheumatoid arthritis, and your rheumatologist finds a good treatment for you, and they try you on methotrexate, let's say, or some other treatment for 6 months, and you have a good response. That's fantastic, but the chances are that you're probably going to need to take that methotrexate for longer than those 6 months if you've had an initial response. And that's the same thing probably with this medication and other approaches for thyroid eye disease, is that we can't expect any approach to necessarily cure it because it is a chronic condition. And that just like with other conditions, we expect to be on more chronic therapy for a chronic disease. If we find something that works, it may just be that we have to find a regimen, how to extend that treatment. So I think it's promising that we have options to treat this condition better than we did before. But it's unrealistic, I think, for the majority of patients for us to think that we're going to have a 24-week treatment and then they're good forever. We would love that, but I don't think it's that. I think the process continues beyond that. And then so we just figure it out. At least we have something that can work. And then now we kind of try to do those conservative things and the sort of the treat and extend idea.
So the idea is behind is to make sure your thyroid level is in balance. So that is the big thing, to make sure not have, hopefully that will keep TED inactive.
I think it's a component. I think that certainly there are, as we mentioned before, there are people that have exquisite thyroid control, but unfortunately still have the TED, the eye disease component, and that can still happen, but it's something that definitely has a correlation. And then perhaps, other things like low salt diet can be helpful, autoimmune, thinking about pro-inflammatory foods, pro-inflammatory approaches. So reducing that, I think, would all be things that if I had thyroid eye disease, I would be looking at all of those ways, to help manage my condition from not exacerbating, and potentially needing, if something worked for me before, like Tepezza, potentially needing that down the road as well in a different format. Maintenance therapy kind of.
And people, a lot of endocrinologists think that cutting the thyroid will help TED, but I heard different opinions. What do you guys think?
Anyone else mention? I can mention that I think that of the treatments for hyperthyroidism, which is the three, the methimazole, which is the medical treatment, the radioactive iodine, and thyroidectomy is probably the most effective at reducing the hyperthyroid component without exacerbating the thyroid eye disease, meaning that the radioactive iodine works very well to make you hypothyroid from a hyperthyroid stage. But as I mentioned before, there are a significant proportion of patients that can have some worsening of thyroid eye disease in that situation. Methimazole is a good treatment. It's obviously less invasive than the thyroid surgery. And it works well at controlling that, but it doesn't necessarily have any positive effect on the thyroid eye disease. Whereas the more abrupt change with a thyroidectomy may have the best way to control the thyroid. But I've seen lots of patients that still have thyroid eye disease even once the thyroid is out. So I don't think it's a treatment for thyroid eye disease. It's just that it's probably the most effective way to make you, not hyperthyroid anymore without exacerbating things like the radioactive iodine does.
So do not remove thyroid because you want to control TED.
I don't think so. I mean, again, endocrinologists would I don't think they would necessarily advocate it solely on the basis of controlling TED, but maybe that's the treatment that they're thinking about to be the best option for that person, meaning that they have graduated beyond methimazole. They're not being well controlled with just the oral agents, but they already have thyroid eye disease, so they don't want to give them radioactive iodine. So then they advocate for thyroidectomy because that's probably the best way to control their thyroid without making their eye disease worse.
A lot of these questions are really patient specific, so it takes the whole team to kind of discuss. Sophia, looks like you have a question as well.
Yeah, Dr. Patel, I'm your patient. I just want to say hi. Okay, I think you answered my question just now because I was wondering, because I had Graves' disease many years ago and I don't have any thyroid issue anymore, but I still have one eye protruding and I also still have dry eyes bothering me. So lately what bothered me is the loose skin on my upper eyelid. And I was thinking about a surgery to remove some of the loose skin. And I just wonder, do I have to have a ocular ophthalmologist to do it, or,
Well, the person that's right next to you on my screen is Dr. E, and she's a great expert at taking away that skin. And I think the main thing, as you mentioned, is I don't think, and Dr. E, correct me if I'm wrong, the dermatochalasis, which is the redundant skin there, it's not necessarily, I mean, that's a change that can occur even if you didn't have thyroid eye disease. But if there was pre-existing swelling and so forth, that can stretch the tissues. And then that can be managed separately. And I'll give it to her in a minute, just managed surgically separately. Probably a good idea just to be evaluated first, just to make sure that all the thyroid disease aspects are not active. And if they're
it's
not
active at all.
Perfect. And then, so if the eyelid issue is a thing that's bothering you, then I think a good consultation with an oculoplastic, not a general ophthalmologist, not someone like me, not somebody that deals with optic nerves or strabismus, an oculoplastic surgeon, which Dr. E is. That kind of person can give you a very good idea about the best way to remove that skin without making it, not just from a cosmesis perspective, but there's so much functional aspect that goes into it and takes a lot of skill. But you'll probably be very happy from it. And then the dry eye aspect, Dr. Lee had some good suggestions. It can be super tricky and can be difficult, but it can be a graded thing as well.
Okay, then, Dr. E, are you in Irvine?
Yes, I'm in Irvine and in Orange.
Okay.
Yeah, definitely feel free to come see me anytime. I will just add, so, you said one of your eyes is maybe still a little bit more bulging. So we'd want to evaluate how well your lids close. And how your cornea is, something that Dr. Lee manages, because anytime you remove tissue from your eyelids, you can exacerbate your dryness. So we want to evaluate that. But in terms of what Dr. Patel said was exactly, perfect. I do find that most of my thyroid patients who are very active will have notable fat pad kind of prolapse and herniation. So as you get older, by virtue of getting older, things tend to sag and deflate.
Yeah.
But I do think in terms of thyroid, it doesn't help. And so it's actually one of, there's a couple of indications that your insurance will cover. And I think having thyroid also just supports even like other aspects of rejuvenation around your eyes.
Okay. All right. I'll make an appointment then. Okay. Thanks.
Look forward to meeting you.
Thanks.
Good idea.
Yeah.
There is a question in the chat. I don't know which of the three of you would best be suited to answer that. It's about vernal conjunctivitis.
Dr. Lee.
Dr. Lee.
We don't see that. I don't see that question, by the way.
Oh, I'll read it to you then. I'm not sure why it's not coming up. It says, can you direct me to information about vernal conjunctivitis? Specifically, once it manifested in a 7-year-old 2 months after relocation to San Diego. Could it go away if the child relocates to another climate, assuming that an environmental factor, perhaps allergy to Alternaria mold from cypress trees, triggers the onset? Or will he outgrow the condition around age 11 to 12, as Google suggests, no matter the geographic location? Somebody's done their homework.
Right. I think they know more about it than I do. Dr. Lee does not look to be on the call anymore. I think she was
She's
driving.
there.
She's there. Oh, sorry. I was trying to like buy time until you got back
Can't
on.
hear you though. Yeah. Still can't hear you.
Dr. Lee.
She's trying to get her microphone on.
Oh,
I think she'll probably be typing a response to that. Are there any other questions while she types the response?
yeah. Let's see what's in the chat.
Can you hear me now?
Yes.
Okay, so vernal conjunctivitis is a completely different disease. I just want to make sure that the audience, other than the person posing the question, understands that this question has nothing to do with the topics of today's lectures. So vernal conjunctivitis is a allergic condition that typically affects children, and like the person who posed the question understands, it, as you said, the child is 7 years old, and there's some component of allergy to a environmental allergen. Children particularly can have very robust immune responses, whether to allergens, and that immune response doesn't necessarily go away, but it's just so much more robust in children, which is why some of these allergies, you don't necessarily outgrow them, but they get much, much better after you're out of the childhood years. There are certainly medical therapies that can treat vernal conjunctivitis. Theoretically, if you could avoid exposure to the allergen completely, that would eliminate the disease, theoretically. Much easier said than done. And, if you like living in San Diego, I'm not trying to tell you to, leave. So meaning there are medications that can be used to manage the disease, whether those are steroid eye drops or eye drops that do not contain steroids. We can work with your child to get the disease under control, until at which point those medications are no longer needed.
Maybe we can take one more question in the interest of time.
Let's see if anybody has any other questions. So another question, how does one know TED become active? Thyroid eye disease become active? This is from Lily. I'm not sure if I said that correctly, Lily.
Sure, yeah. So how do you know when your thyroid eye disease is active? So that's really a clinical exam. And so based on how you know, your symptoms are and how your eyes look. So this, I think Dr. Lee and Dr. Patel had a lot of pictures kind of demonstrating this, but the injection, the inflammation, the redness in and around your eyes, the pain at rest, pain with eye movement, and then symptoms of double vision and a few other things. But it's really that there's like a host of different ways to measure or evaluate it, but one of them is the clinical activity score that I mentioned. But that really kind of reflects how active your disease is.
Yeah, active patients are just swollen, right? They have this congested look. It's not so much how far the eyes come or how bad their strabismus is, just as Dr. Yi mentioned. All those things that happen in the orbit that cause those fat cells to become more numerous and to become swollen. And that water-based kind of gelatinous material goes in into the muscles and causes congestion, and not just the muscles, but the tissues around the eye too. So you look swollen and congested. To me, when I see a patient that I think is active, they have swollen tissues.
Great. If there are no more questions, we'll wrap up tonight, but not before I let you know about the upcoming lectures, of course. February 7th, there's a dry eyes lecture with Dr. Marjan Farid. March 7th, an AMD lecture with Dr. Liu and Dr. Mehta, and a low vision lecture April 11th. The rest of them are on our website. I won't read them all to you now, but we hope you'll find some that are interesting and sign up. Videos will be available on our website in the coming weeks. So thank you all for joining us. Dr. Ediwrickrema, Dr. Patel, Dr. Lee, thanks always for such a great lecture.
Thanks for putting it on. Nina.
Thank you.
Thank you.
Good night.
Good night, everyone.
Good night.